He's a master trainer in the management of HIV/AIDS at WHO, NACO, and CMC Vellore. Dr. Naval Chandra is the Associate Professor, Department of Medicine, Nizam Institute of Professor of Medicine and Medical Ethics, St. John Medical College, Bangalore. He's the Master Trainer in the Management of HIV/AIDS at WHO, NACO, and CMC Vellore. Dr. Naval Chandra is the Associate Professor of Department of Medicine, Nizam Institute of Medical Sciences, Hyderabad. He has over 12 years of experience in the field of HIV. I would request them to carry forward the proceedings of the next session.
Good morning, and now from the old abstract presentations, we'll move on to the talks. And the first session of this conference is on emerging trends of HIV epidemic. I may now call upon the first speaker, Dr. Sheela Godbole from NARI, and she's going to present on epidemiology of HIV infection in India. Over to you, ma'am.
Thank you, Dr. Chandra, Professor Ravindran. Good morning. It's indeed a pleasure to be here, and I thank the organizers for having invited me. About 31 years ago, the Indian Council of Medical Research had actually established a task force to look for AIDS in India. They found no AIDS, but they set up laboratories to look for HIV. Within a year, we reported the first HIV infection, and then the first case of AIDS in Mumbai. Thank you. And now, where are we 3 decades later? So I won't belabor the numbers over here because this has been mentioned by many of our speakers earlier today. But with 2.1 million estimated infections, we have less than 1 million on ART. We had 68,000 deaths in 2015. However, we have estimated decrease in new infections, decrease in the numbers of people living with HIV, and decrease in the deaths due to HIV infection. So if you look at, I can't find, just one more. So if we look at the graph on the left, what we see is a slow but steady decline in the prevalence of HIV over time since 2007, which is a base year for the current program of National AIDS Control Program, iteration of the NACP. And the prevalence, estimated prevalence of HIV at a national level is 0.26% among adults, men and women, which is a which puts India into a low prevalence country. However, we still have the 3rd largest burden of HIV in the world, and 40% of those with HIV are women. And nearly 7% are children below the age of 15 years. What we have shown is a decrease since 2007, a 32% decline in the burden of HIV over time. So where are these people who are living with HIV in this vast country of ours? And what we can see over here is that majority of them are in the states of Andhra Pradesh, Telangana, Maharashtra, Karnataka. Probably Tamil Nadu, Gujarat, Bihar, and Uttar Pradesh have similar proportions of the burden of HIV. And then we have the erstwhile low prevalence states, the northern states, where we are seeing an increasing burden of HIV. And that's probably also related to an extent with the testing and care activities that are ongoing. But I'm talking still about estimates. But what have we done? So on the left-hand side, we see the estimated numbers by state. And what we see on the right is the cumulative numbers of people who have been detected or tested at the integrated counseling and testing centers since 2007. And we see that we continue to have some challenges in testing and identifying people living with HIV, especially in the lower burden states, but where we see increasing burden lately. So typically when we look at the epidemiology of HIV, we need to look at data that comes from multiple sources, all of which feeds into the estimates and the numbers that I just talked about. However, for India, the primary basis for the HIV estimates has been the HIV sentinel surveillance, which has really emerged and strengthened over time since 1998. Since then, what you can see on the left are the numbers of HIV sentinel surveillance sites, which have increased. We have the antenatal clinic surveillance sites in blue, the surveillance sites for bridge populations, which were primarily at STD clinics, which have now been phased out, as well as those sites which were with long-distance truckers, and the migrant sites. And then we have the sites among the high-risk groups. The last HIV sentinel surveillance, which was done among the antenatal clinics, was done in 2014. And the IBBS study, which was a community-based biological and behavioral study, was done in the years 14 and 15. What you see in the three figures on the right of the slide are how a pictorial description of how the sites have been ramped up over time, improving the data. But what we see over these years is that our epidemic has become, has always been, but has been increasingly identified as a heterogeneous epidemic. And the figures that you see are the way the epidemic has moved and the prevalence, the erstwhile high prevalence states that we had always been talking about since 1998 went on to become less burden HIV states, while we began to identify more of HIV in the north. The northeast and the south had always been high prevalence states. So this is what the HIV sentinel surveillance showed in 2015, where we had probably just one state in the northeast with a prevalence of more than 1%, and a majority of the southern and some of the states on the northwestern border of India showing a higher prevalence. But if we really try to look into this data again, and we look at the district level, the picture becomes much more heterogeneous. What we see over here is the states are not very uniform in terms of their HIV prevalence and therefore burden, but you see pockets of high HIV prevalence, so we see the red colors much more frequently in every state and at the district level. So this has, over time, helped us shift the focus from the states to the districts. Again, this is another example how the targets have been moving over time. This is again a look at the district level HIV prevalence from 2003 to 2015. And then we see, if we just look at it, that there were so many districts which had a prevalence of more than 1%, especially concentrated in the southern states of India and the northeastern states, which have slowly improved with time. So now we are identifying such districts more in the central and northern parts of India, and the focus is now shifting to the low prevalence states, but with district level focus rather than a state level focus. We also have to understand that at this time, just as the epidemic landscape has been changing in India, the prevention landscape has also been changing. In the last few years, we have seen more and more evidence about the impact of treatment on prevention, and therefore, just as efforts for intervention were focused not just on condom use, it is now time to look at how antiretroviral therapy is accessed, especially among the high-risk groups. So once again, let's go back to trends in the antenatal surveillance. And what you can see in the graph on the left is overall the trends of HIV among women who attend antenatal clinics have steadily decreased over time. But if you look at the low prevalence states in the eastern region and in the northern region, the two lines right at the top and at the bottom, we see that there is still a lot more work to be done. If we look at the antenatal prevalence in just Gujarat, Punjab, and Rajasthan, what we see and what we have identified is actually what seems to be an increasing prevalence in these states. And if we look at some other states like Uttar Pradesh and Delhi, we see the same picture. So this once again reiterates what I've been talking about. So in India, while it's a low prevalence epidemic, we have concentrated epidemics in key population. And this is the classic picture that is used in the epidemic modeling, which shows the different key populations. And in India, the driver primarily of the epidemic is purchase of sex by men. But we have epidemics among female sex workers, men having sex with men, transgenders, and persons who inject drugs. So we really are fighting the war on all the fronts that we can, and the impact on the clients and the low-risk population. India also has a large burden of the populations at risk of HIV. These mapping data are slightly older, but you can see over here that numbers are very large. One of the biggest challenges for us specifically are the larger estimated numbers of men having sex with men. If we look at HIV prevalence among key populations, these data on the left are from the HIV Sentinel surveillance, which were sites that are primarily located at targeted intervention sites. So sites where the program is providing intervention, which is a graph on the left. And we see that overall the epidemic seems to be stabling and coming down, of course, especially among the female sex workers, where the prevalence currently is was 2.8 in 2011, 4.4 among men having sex with men, and a larger problem among persons who inject drugs. However, the community-based integrated biological and behavioral survey that was completed in 2015 showed slightly similar pictures among female sex workers and men having sex with men. However, we have a much higher prevalence among persons who inject drugs. This study actually looked at, it sampled in the community, and we had a proportion ranging from 30 to, in some places, 40%, actually 10 to 40% of people who were outside the targeted intervention, who had not been exposed to the program. So the concentrated epidemic, it was concentrated and it continues to remain concentrated. On the left-hand side, you can see the data from the Sentinel surveillance and the IBBS among the different, okay, so I will just go ahead. Not all the states in India have the same level and drivers of the epidemic. We are finding epidemics in newer locations among IDUs. And we find that our interventions seem to be working, especially among the female sex workers and among the men who have sex with men. We actually, in one of our papers in 2011, showed how the scale-up of targeted intervention programs and access to condoms actually impacted the HIV epidemic. Currently, in the IBBS survey, we find that there's a very high uptake of condoms among female sex workers, except that they don't use them as frequently as they should. In fact, extremely low use with non-paying regular partners. And if we look at the awareness of ART among these women, there's a big range of ART awareness and possibly uptake, because the direct question was not asked in the IBBS. But we find that in the northeastern states, female sex workers were had a much better knowledge of ART as compared to the low prevalence northern states. Condom use among MSM is much lower than we see among female sex workers. These are the most recent data. While there is a variation, but a reasonably good picture of using of sterile needles among persons who inject drugs, but the proportion of people who are not in the program was lower in this population. Condom use among people who inject drugs is very, very low. So achieving the first 90, India has updated its ICTC facilities, and the number of tests especially has improved for pregnant women. But linkage to care also has increased with the number of ART centers. But if we look at the detections of ART by CD4 count, if we see that we are still detecting most of our infections below 500. So we are not really seeing the people who are getting infected earlier. If we look at the cumulative cascade for HIV treatment and care, if we assume that there were 2.1 million estimated PL-HIV, we have about 1.4 who were diagnosed, 1.1 who were enrolled into care, less than 1 million on ART. We are yet to look at the other 90 goals. We can't be complacent, because 29% of the new infections were in the Asia-Pacific region were still reported from India. And there is a lot of work to do if we really have to achieve our goals. But what India is now progressing towards is elimination of congenital, of transmission from mother to child. And if we look over here, we see that we have quite a few states which have achieved a very good level of testing among women who are registered in the health information system of the National Health Mission. But the overall level of testing among pregnant women is still only 45% across the nation. So much has changed and a lot remains the same. But the focus continues to remain on the key populations in the concentrated epidemic. And I acknowledge NACO, CMU publications and slides that I have used in this study. Thank you.
Thank you, ma'am, for giving us an overview of where we are heading in terms of the epidemiology. Do we have a question or two? Right, if there are no questions, thank you very much for your presentation, ma'am.
Thank you, Dr. Sheela. I would request Dr. Naval Chandra to kindly give a memento of thanks to her.